and we're going to talk about swallowing disorders and head and neck cancer. Most head and neck cancer begins in cells that will line the mucosal surfaces that is, throughout your head and neck region. This may be in the mouth, the nose, and the throat. So a mucosal surface is any moist tissue that lines organs or other cavities in the body. Mucosal surfaces are lined with epithelial cells, and that overlies loose connective tissue. So head and neck cancer is identified by the location of where it's growing. So it might be in the oral cavity. So as you see, the lips, the front 2/3 of your tongue, the gingiva, also known as your gums, could be in the buccal mucosa, so inside your cheeks. It could be the floor of the mouth, underneath the tongue, and also on the hard palate. For salivary glands, we have many different salivary glands, and the major ones include the parotid glands on the inside of your cheeks. You have submandibular glands at the floor of the mouth. You have sublingual glands under the tongue, and the parotid gland near or behind the nasal cavities. And this next slide here, oh, I'm realizing that's a little blurry. I will fix that for you all in the hard PowerPoint presentation that you have. So any slides you see here that are not in that presentation, I will fix for you. But here you could see the different locations for the major salivary glands. We may also find head and neck cancer in the paranasal sinuses, kind of behind the nasal cavity, maybe in the pharynx, could be at the larynx, and lymph nodes that are in the upper part of the neck. This picture here shows you the most common locations for tumors in the oral cavity. So this is where tumors in the oral cavity most frequently occur. You can see on the hard palate here. You can see on the soft palate. Here is like the alveolar region and lateral floor of the mouth. Also around this tonsillar region and the falcial pillars. Here's lateral tongue and at the base of the tongue. So this is way posterior, the base of the tongue, not oral tongue. Here's base of the tongue, and then the lateral floor of the mouth shown here. There are several risk factors that increase the likelihood of somebody developing head and neck cancer. So they are listed here for you. Smoking, drinking, positive for the HPV virus. Even secondhand smoke can cause cancer in somebody who was never a smoker. Dietary antioxidants can create an increased risk, as well as genetic factors. So if somebody in your family has had cancer, you are at a greater likelihood for having cancer. The ways in which you make a diagnosis: there's an examination that is required by the otolaryngologist, same as your ENT. Lab tests must be run to look at your blood work. They will also do imaging studies. Which study that is will depend on the location and type, and then also a biopsy to confirm the presence of the cancerous cells. There are several people who might be involved when somebody has a diagnosis of head and neck cancer. You can read through the list here. And then we come on this portion in terms of the team. So physical therapist, speech therapy, social work, etc. Prosthodontist might help with restructuring for dentures, modifications, after removal of jaw or teeth. Dentist can also come into that role as well. And a dietitian to help make sure that the nutritional content is being maximized for any particular patient. The next 3 slides talk about common symptoms that the person may present with. So it could be a lump in the neck. It might be that the person identified it themselves. Maybe they were shaving, for example. Men may tend to find like a little pea-sized lump somewhere. It could be a change in their voice. So it could be change in vocal quality or resonance depending on the location of the tumor. Complaints of persistent nasal congestion are made at times. Any presence of a growth somewhere. So it might be a sore or swelling that does not go away. Oftentimes it's painless. There might be some bleeding that may occur with that in that location over time. The person might bring up blood. So if there's a tumor in the nose or the mouth, the throat or the lungs, when they blow their nose or if they're coughing, there might be blood associated with that. And of course, dysphagia can be a symptom of head and neck cancer or tumor. Excuse me. Other common symptoms are changes in the way that the skin appears. Complaint of persistent earache. So the patient might say that there's constant pain in their ear, around their ear, and especially when they're swallowing, that pain is exacerbated. There might be changes in the way the denture fits because if they have a presence, for example, of a tumor near the facial arch or on the velum, that denture can't adhere or fit the way it normally does. And there might also be a loss of sense of smell. The main medical treatment for the tumor involves typically a resection of that tumor in the oral cavity, the pharynx, the larynx. If lymph nodes need to be removed, then this would involve a modified radical neck dissection. They go in and they remove those lymph nodes. And or the person may have radiation or chemotherapy after they've gone through surgeries. Okay? So the method used will depend on the site and the extent of the lesion. So tumors can be treated with surgical resection or with radiation, without surgery, and with radiation with or without chemotherapy. All right, now we're going to talk about the type of resections and reconstruction. So the type of resection as well as reconstruction depends on the size and the location of the tumor. So it could be a partial tongue resection. It might involve anterior floor of the mouth resection or lateral floor of the mouth and or base of tongue. So let's first take a look at the partial tongue resection. Your textbook talks about the 50% rule. This 50% rule suggests that less than 50% removal of a structure will not result in a significant and permanent swallowing problem. Okay, so less than 50% of the tongue, the swallowing problems are probably temporary in nature. And we're talking about tongue and no other structures or tissues involved. So in this instance, less than 50% tongue involvement, problems are usually temporary. They may be associated with edema or changes in tongue movement because of a resection portion of the tongue that was removed. You tend to see that the swallowing reflex is delayed. Thermal-tactile stim can be helpful for this particular population. There might also be decreased coordination of the tongue, in which case range of motion exercises or exercises for bolus control might be warranted. Using the IOP for oral tongue exercises with head and neck cancer population has actually good evidence to support its effectiveness. You tend to see improvements when less than 50% of the tongue is involved in about 3 to 4 weeks post-op. Let's move on to more than 50% tongue involvement. So in this situation, we see severe oral control problems, especially with that lingual propulsion and bolus control. Because of the limited amount of tongue remaining, that tongue cannot reach the palate, which is necessary to have control of the food. Some patients can tilt their head backwards, what we might call a dump and swallow strategy. And some patients can swallow liquids or thinned paste consistencies, using that head up to help propel the bolus posteriorly into the pharynx. If only the tongue is involved and the pharyngeal and laryngeal aspects of swallowing are normal, then we tend to see less problems. But the supraglottic swallow can be taught as a precaution against aspiration. So let me just restate that. If only the tongue is involved, usually the pharyngeal and laryngeal aspects of the swallow are normal. So a supraglottic swallow, though, could be used just as an added precaution, even though pharynx and larynx aren't typically affected in this situation. Some tumors of the floor of the mouth might be treated with excision of the tissues involving only the floor of the mouth. More likely, a large tumor will involve resection of the floor of the mouth plus the adjacent mandible and even perhaps a portion of the tongue, or in some cases, the entire tongue. In other instances, they may also need to do a radical neck dissection to remove associated lymph nodes that are involved. For the floor of mouth resection, the surgeon uses a flap of tissue from somewhere else in the body other than the tongue. Typically, they'll take this from the forearm, their chest, might be the shoulder area. And he will use that flap of tissue to recreate the floor of the mouth. In other instances, the surgeon may actually choose to suture the tongue to the lip or some other site. So in which case, there is nothing that can get beneath it. There's beneath the tongue, and that lip and tongue are sutured together. When the upper part of the mandible and a portion of the floor of the mouth are removed, and the surgeon does not use the tongue for closure, then lingual propulsion of the bolus and bolus control in the oral cavity is typically good. You might see increased transit times, which can be decreased by placing that bolus more posteriorly in the mouth, especially when there's still a lot of swelling at the early stages. They actually have what are called glossectomy spoons, which help place that food more posteriorly. When there is tongue suturing to the lip, the patient is going to have greater difficulty with anterior range of motion and difficulty with holding that bolus in preparation for the swallow. Chewing is nearly impossible. The patient cannot use their tongue for lateralization. Depending on the severity of the reduced tongue movement, a syringe could be used again for this dump and swallow technique that I was mentioning before. But they must have a good trigger the laryngeal swallow. You can introduce that supraglottic swallow to make sure that airway closure is achieved and additional protection is provided. Sometimes later on, the surgeon may free the tongue and do a graft or a flap for the floor of the mouth at a later time. Okay, we're moving on to lateral floor of mouth and base of tongue resections. So this may include tonsils as well. Keep in mind that the facial arches or a portion of the pharynx may also be involved in the resection. So that in that case, the pharyngeal stage of swallowing will be impaired as well as the oral stage. The exact problems that the client will present with, of course, will depend on exactly how that resection was done by the surgeon. So if we think about oral phase problems, expect that you might see mild to severe deficits with oral prep, chewing, oral transit, and or AP propulsion. You'll probably see some residue in the lateral sulcus and on the hard palate because of that reduced range of motion of the tongue. They're going to have a difficult time clearing any residue. The client may also present with a delayed trigger for the pharyngeal swallow, especially when you have facial arch involvement and potentially with tongue base involvement. So with the presence of decreased trigger, this is going to be associated with reduced sensitivity. In terms of pharyngeal phase problems, because of tongue base, you will see a residue left over. Where will that residue be located? Yes, in the vallecula after the swallow. If the pharyngeal wall is also affected, then you would also see residue on the pharyngeal wall. Think bilateral or Unilaterally. Yes, it would be bilaterally. Laryngeal control in terms of elevation and laryngeal closure is typically normal. You may see esophageal problems presenting in these individuals. Specifically, there may be difficulty with cricopharyngeal sphincter opening. In these instances, the Mendelssohn maneuver could be helpful, especially because these patients are cognitively intact. And also exercises to help with laryngeal elevation, maybe falsetto could be effective. So in terms of the types of treatment we might be thinking about for these individuals, for improving the range of motion and strength of the oral tongue, the IOP would be appropriate. For tongue base range of motion, what would be important or potential strategies? The effortful, gargle, yawn are all evidence-based. What about the pharyngeal swallow? How could we improve the trigger or decrease the delay? Yes, think thermal stim has shown to be effective for some individuals with head and neck cancer. And lastly, we might want to teach a protective strategy like the supraglottic swallow. We talked about that earlier, and again, because these clients are cognitively intact, that is going to add additional protection of the airway. Now I want to talk about some of the potential problems that may occur after radiation therapy. So some individuals will have radiation instead of surgery. Some will have radiation in addition to surgery. And most, if it's cancerous, they're all going to undergo some degree of chemotherapy. So you can see listed there the variety of oral stage problems that a client may present with. So xerostomia, that should be an O, xerostomia. This is also known as a permanent reduction in saliva in either some or all of the salivary glands that were in that field of radiation during treatment. This is often very upsetting to patients because medications to treat xerostomia are really only partially effective. Oftentimes, patients will carry around with them something called biotene, biotene. This is an oral spray that can be purchased over the counter, and they will use that to help with the dry mouth sensation. If you want to see what it feels like to kind of have that dry mouth, go ahead right now and try to swallow 6 or more times in a row. Don't take a drink first, that's cheating. And you'll really see how hard it is and how uncomfortable that dry sensation is. Many clients may also see reduced speed of tongue movement, and this is going to negatively impact that oral transit time. And it can also affect the pattern of the tongue movement, which can in turn affect or contribute to the presence of a delayed trigger of swallow. Another thing that clients may develop is fibrosis. So fibrosis is change of muscular fiber into connective tissue, and this results because there's damage to the small blood vessels that innervate those muscles. So in the radiated area, the muscular tissue surrounding those blood vessels are restricted and damaged, and therefore the muscular tissue basically turns into a connective tissue. With respect to the pharyngeal problems, you may see residue in the pharynx after the swallow because of the reduced pharyngeal contraction. This may lead to aspiration after the swallow. Think about what we might do to improve or reduce the risk of aspiration secondary to residue on the pharyngeal wall. What treatment might that be? Yes, potentially we could do the Masako as long as head and neck is able to move accordingly. And you might want to check with the surgeon for that because of the head flexion. If we have reduced tongue base retraction, this can again leave residue wear. And the vallecula, good, we talked about strategies just a moment ago. And in terms of laryngeal elevation, Again, the Mendelssohn or falsetto. Some additional management strategies that we might do is to teach the patient some range of motion exercises. So it's good if you do have one consult session with the client prior to any radiation therapy. You can teach them some range of motion exercises for their jaw, for the tongue, and then also for the larynx. So range of motion exercises for the tongue literally would be opening their mouth, moving right, left, up, and down. And this does have this is important because of the restricted range of motion as the muscular tissue tightens after radiation. In terms of the tongue or tongue base, if it's oral tongue, the IOP, if it's tongue base, then we could teach yawn, effortful swallow, or the gargle. The use of range of motion exercises is thought to help slow or reduce the development of the fibrosis. The supraglottic swallow, as we mentioned, to add protection for the airway, and the Mendelssohn for laryngeal elevation as well. Swallowing problems after radiation also can surface after several months or sometimes even after a year or more. So it may not be immediate, and you may have patients who come to you even a year or so after they've had radiation. Most of the time after surgery, the client is sent to the speech pathologist, and you'll start to see improvements in speech or swallowing, right? So they've had surgery, they go to speech therapy, but then they're going to start radiation. So usually about 4 to 6 weeks post-op, that is when the client starts radiation for about a 6-week cycle. So 4 weeks into that 6-week radiation cycle, you may have clients now regressing. They're actually worsening because of the onset of the radiation and the impact it's having, even though they looked like they were really good and making good progress post-operatively. All right, we're not going to look at these videos. Let's talk a little bit about principles of swallowing treatment with our clients who have oral cancer. It would be ideal if we could get in one pre-treatment counseling session. Obviously, you will not know the extent of damage that the client is going to present with, but there are specific potential problems that you want to discuss with the patient as well as any significant others who might be at the session with the client. First of all, you do want to find out what they know about their situation. You do not want to be the first person to divulge that they have a cancer if this has not already been discussed with them by their physician. Secondly, you want to make sure that they know that after surgery they will awaken with a feeding tube. This is usually an NG tube, so feeding tube will be in their nose, and that this is temporarily how they will meet their nutritional needs. It's important that they understand that for the most part it is temporary, but they will wake up with this in place. And if you can help the client understand the difficulties that may present, that they're going to face with respect to swallowing, this can also help help them manage their emotions after they wake up from surgery. I know you all talked about a client who was not informed that she would not be able to eat, and that was the client who had a laryngectomy. And that would be a horrible, devastating way to wake up without having any knowledge that this was coming. Okay, so just to review: 1, find out from the client and the family what they already know about their situation and regarding the surgery. 2, let them know that they will be awakening with a feeding tube and that this is temporarily how they will meet their nutritional needs. And 3, you want to discuss the importance of the client's compliance with an exercise program. Okay, they need to understand that this is not going to be an automatic process after surgery. They need to be an active participant, and it's important that they do whatever exercises you recommend. So once the client has healed enough from surgery, usually 10 to 14 days post-surgery, the physician will let you know that it is okay to go ahead and start doing some exercises. Sometimes what we'll do is tissue massage. You can teach the client how to massage on the scar tissue and you do it perpendicular to the direction of the scar. Doing this massage, even with their fingers, sometimes you can find like sharper images only online. There used to be Brookstone stores that would have the small little handheld vibrating massages. So you can use that as well. But this is something you want to teach the patient to do, and this helps to reduce the potential development of fibrosis. Jaw range of motion exercises, as well as the tongue range of motion exercises, are especially important if they're going to be undergoing additional radiation following surgery. You also need to think about if this is a client who had a resection where a flap of tissue was taken from the neck region or pectoral area. It might be important to teach the client some head and neck stretching, but you need to be careful and make sure that the range is acceptable, given physician permission. In terms of your fluoro assessment, most patients will be able to eat on some sort of diet consistency. Usually it will be thin liquids at first, and then more viscous consistencies can be introduced as oral motor function improves. Remember, they may have difficulty with AP movement, so thicker is going to be harder to manipulate. Based on what you see on your fluoro assessment, you're obviously going to determine your treatment plan given what you have observed. Clients are typically seen on an outpatient basis for several months post-op. Okay, so again, think about the discussion that you're going to have with your clients. It's going to include pre-treatment counseling, where you discuss and find out what they know about their surgery and why they're having surgery, presence of a feeding tube, and importance of compliance with an exercise program. Larynx. So you may have supraglottic tumors, you may have unilateral laryngeal tumors, or lesions that involve more than one area. I just want to clarify first the difference between laryngectomy, ending in T-O-M-E-E, versus laryngectomy, T-O-M-Y. So with laryngectomy, T-O-M-Y, this is the procedure to remove somebody's larynx, and laryngectomy with E-E on the end is the person whose larynx has been removed. Just like with oral cancer, when we have laryngeal cancer, treatment might involve surgery, it might involve radiation, it might involve chemotherapy. Additionally, somebody may have a partial laryngectomy or a total laryngectomy, and we'll look at the differences across those. So first of all, let's look at supraglottic tumors. So if it's supraglottic, that means it's located above the ventricle. The ventricle is the space between the false folds and the true folds. So we are typically talking about smaller lesions. They may also involve part of the epiglottis, part of the area epiglottic fold, or part of the false folds. So individuals who undergo an uncomplicated partial laryngectomy procedure, an uncomplicated partial laryngectomy procedure. This may also be known as a horizontal or supraglottic laryngectomy. These individuals will typically regain normal swallowing without any aspiration about 1 month, give or take on average, post-surgery. For the uncomplicated partial laryngectomy, surgery involves elevating the remaining larynx. The surgeon does something where they tuck it under the tongue base and kind of create folds with the remaining tissue to provide airway protection during the actual swallow. Because the epiglottis, the area epiglottic folds, or the false fold may no longer be present with this procedure. When there are larger lesions, the procedure may extend superiorly to the hyoid bone, to the tongue base, or it may extend inferiorly to one of the vocal folds or arytenoid cartilages. When you have an extension to the tongue base, you'll see problems such as premature spillage of food into the airway entrance. These patients typically exhibit reduced lingual movement and reduced bolus control. So you need to do treatment approaches that will target those areas. So in terms of lingual movement, the IOP, and that can help with overall coordination as well. You may also see decreased sensation affecting a cough response or delayed trigger of the swallow. So again, for decreased sensation, thermal stim has shown some effectiveness for head and neck cancer clients. Usually, when you have extension to the tongue-based, you're going to see more than 6 months are needed before returning to some type of oral intake. If the surgeon needs to extend the resection to the vocal folds or the arytenoids, now you have a situation where the client has limited protection, even more so than just the supraglottic laryngectomy. The arytenoids were a major contributor to that airway protection. So if they've been removed, we no longer have that as a consequential residual structure to give some protection. Individuals with extended resections involving the arytenoids will require at least 2 months recovery time, and sometimes 6 to 12 months of rehab therapy before they're able to return to some type of oral intake. In some instances, with that extension into the vocal folds and or the arytenoids, the person may never be able to drink or eat without aspirating to varying degrees. Let's now look at swallowing disorders associated with unilateral laryngeal tumors. So when the tumor is located on the free margin of one vocal fold, when this is the case, what happens is that the surgeon removes 1/2 of the larynx. So when we're talking about half the larynx, this includes one false fold, the space beneath it, one true vocal fold, and a portion of the thyroid cartilage on the same side. The surgeon does tissue bulk reconstruction on the operated side so that the unoperated side of the larynx can do its best to attain a normal laryngeal closure during swallowing. So you have one working vocal fold, tissue bulk built up on the side that underwent surgery, with the goal that the remaining vocal folds will be able to make contact with that tissue bulk enough to give protection for swallowing. The chin tuck is often used in this situation because it will help to push the epiglottis more posteriorly and help to narrow the entrance to the airway. That is, it provides more protection. If aspiration is still present with a chin tuck, the addition of the head rotation to the operated side should improve laryngeal closure. Use of this strategy is typically only necessary for a few weeks. In many instances, however, the procedure must be extended anteriorly or posteriorly when you have unilateral laryngeal tumors. So with an anterior extension, if the tumor is located in the anterior position or the anterior portion of the vocal fold, the resection may involve the anterior commissure of the larynx or even the other vocal fold. So if it includes the anterior commissure or potentially that additional vocal fold, this might be considered a 3/4 laryngectomy. So even in this scenario, when they have to take the anterior commissure or extend into the other vocal fold, because of the way the reconstruction is worked by the surgeon, and because you still have the arytenoids, your epiglottis, and the hyoid bone, with the new tissue bulk, protection against aspiration may actually be okay when using both the chin tuck plus the head rotation. If you have a posterior extension, this includes the arytenoid in addition to the one true vocal fold, one false fold, space between them's gone, and the portion of the thyroid cartilage. So in addition to that, you now have arytenoid cartilage being added. Research has shown that these patients tend to require a longer rehabilitation period than compared to the other extension. So posterior extension tends to have a longer recovery than the anterior extension or unilateral laryngeal tumors without extension. Some of these individuals may never be able to drink liquids by mouth because of aspiration during the swallow, and oftentimes they will need a permanent tracheostomy. This trach is also used for suctioning purposes to help eliminate aspiration. These clients would also require laryngeal adduction exercises that could help for the remaining vocal fold to achieve better closure, and then also implementing chin tuck with the head rotation as a strategy to prevent against aspiration during the swallow. Now, in all of these cases, you have to see this on fluoro. This is not something that you could just do at the bedside. You must see this on fluoro. Well, or fees would be an option as well. Okay, so looking at situations where there's multiple regions of the larynx that are involved and will be removed. So just to review, excuse me, when we're talking about regions, we're talking about supraglottic, so above the vocal folds, the true folds that is, glottic at the level of the vocal folds, or subglottic beneath the vocal folds or below the vocal folds. So if more than one region of the larynx is involved, then this usually requires a total laryngectomy procedure. The positive or silver lining to a total laryngectomy is that there is absolutely no risk for aspiration because the respiratory system and the gastrointestinal tract are completely physically separated from each other. However, there are several post-op problems that do or can present in laryngectomy situations. One of these is called a pseudoepiglottis. So a pseudoepiglottis is a fold of tissue that forms at the base of the tongue after surgery. And this fold of tissue that shouldn't be there actually forms like a pocket that collects food and liquid during swallowing. Some patients might only be able to have a little bit of liquids to avoid it getting caught in there, and surgical resection can help in certain situations. The presence of a pseudoepiglottis can actually cause backflow or food coming back up into the oral cavity. And this can be treated surgically, as I mentioned. One of the signs that this may be problematic is that there could be bad breath or chronic halitosis because the residual food is always stuck in there and the patient may not be able to clear it. Another problem that can occur is tightness of surgical closure. So when people have multiple regions resectioned, the closure, it involves a more extensive resection of the pharyngeal mucosa, and as a result, the surgeon needs to do a tighter closure. So scar tissue strictures, remember stricture is a narrowing, can form at the opening of the esophagus, and as a result, this prevents large amounts of material or thick consistencies from passing through the esophagus. When the strictures occur or it is too tight, this requires that dilation be done. So dilation is a procedure where patients are asked to swallow increasingly larger sized balloons that are then gradually expanded to help stretch out the stricture. The problem with dilation is that it does not last, and over time the tissue returns to its tight original state, and therefore they have to go back to the doctor frequently to go through this dilation process on a regular basis. Like a pseudoepiglottis, the problem with a stricture can also result in backflow of food. Okay, we're not going to show any fluoro videos, so this brings us to the last slide here. We already discussed the pre-treatment counseling session earlier on in this lecture, so I would encourage you to review that. But in general, in terms of exercises, we frequently saw a recommendation for tongue-based range of motion exercises. This was with residue in the vallecula, and that was seen in many of the partial situations. And doing so would help to reduce that residue with the yawn, gargle, or effortful swallow. Also, we talked about the Mendelssohn for laryngeal elevation. Falsetto exercise may also be helpful for these clients. We know that all of these clients are going to require a fluoro or a FEES to see what is going on with their swallow and how safe they may be. Depending how long after their surgery that they are having the fluoro assessment or FEES, the patient may actually begin to eat on that same day, and some of them might be able to be on a normal diet, especially if it's after a total laryngectomy. There should not be any issues there. Remember that you do want to try compensatory strategies during your fluoro or FEES assessment to see how effective they are and what is best. If they are not able to return to oral intake after this assessment, then you want to have them do a home therapy program for about 2 to 4 weeks and recommend that they come back for reevaluation at that time. All right, that's all for us. We're going to close out now and have a good evening.